Sudden cardiac death is a very scary subject. Generally that's seen in people that have structural heart disease, so previous heart attack is the most common, and they have a weakened heart muscle. They can have sudden, fast, lethal heart rhythm problems that are not predictable, and people will keel over dead from this. Again, you've seen people on the news. Most recently it would be Carrie Fisher had a cardiac arrest on a plane. They really couldn't resuscitate her in time, and she ended up passing on. So people that have sudden death generally have about a 1% chance of surviving that outside the hospital, if they're not in the hospital setting. So if you're lucky enough, the paramedics will get there within 5 minutes of somebody having a cardiac arrest, you or somebody, and they will shock the heart back to life with the defibrillator. Unfortunately, that doesn't generally happen. The odds are against that. If I have a defibrillator in my chest, an implantable defibrillator, and I go out and have sudden death, go out on the street and have sudden death, the device will detect that about 1 to 2 seconds. It will charge up, which takes it about 5 to 10 seconds, and it will shock my heart back to life. The chance that I will survive sudden death is about, with a functioning defibrillator, I'll say it's between 95 to 99%. So it totally flips the odds in your favor. I tell people if I put in a defibrillator to rescue them from sudden death, I hope it never has to work. In other words, we never want people to have a cardiac arrest, but if you do, it's there. For most people that have a device, a defibrillator will not make them feel better, it won't make them faster or stronger, it's not going to turn them into Superman. All it does is instead of giving them a better quality of life, it improves the quantity of life. So if you're satisfied with how things are going and you want to live longer, this may be a device for you. Again, we hope we put it in, and if we put it in, it never has to work. That would be a good thing. The battery of the device lasts about 3 to 5 years. It generally lasts longer than that, but I'll just say that for now. And then it has to be changed. Generally, that surgery is a smaller surgery, same-day surgery, which we'll go into in a second. There are problems with devices. Sometimes they can deliver what's called inappropriate shocks, so they can shock for something that's not related to a cardiac arrest. But the devices are very good, very reliable. Leads are very good, very reliable. So a lot of times somebody might go to the ER after they had a shock from a device, and the ER doctor will say, oh, your device is malfunctioning, it shocked you. And what happened is they had a cardiac arrest, the device shocked them back to life, and then you can show them that, welcome to the rest of your life because this device was there and it rescued you. So the chance of inappropriate shocks are getting to be much smaller than they used to be. I think that it's okay for people to not have a defibrillator, even if you're at high risk. I mean, that's really an individual decision. I'll say 10 to 20% of people that I talk to about having a defibrillator decide that they do not want that, and I think that's okay. I mean, it is, if we're going to go suddenly, I think that's a good way to go. Obviously, I don't want to suffer if I'm, going to die at some point, and I don't think anybody really does, but again, that's an individual decision, and again, we're talking about prolonging the quantity of life, not necessarily the quality. So again, it's individual about whether you want that. There obviously is issues. You have surgery, you have this device that has to be followed and checked periodically. So it's really up to the individual person whether they want that. Having defibrillator surgery, somewhat similar to pacemaker surgery. Nothing to eat after midnight. We hold all anticoagulants generally, almost always. The antiplatelet agents like aspirin, Plavix, and Effient, usually we would continue a patient on that. Things like Pradaxa and Coumadin and things are going to be held. The doctor will tell you what medications to hold or take, if any. Usually we'll hold diabetes medicines the morning of surgery. You'll have antibiotics given before and after. The anesthesiologists make you very sleepy. It's a lighter sedation called conscious sedation. If you wake up and you feel something, you just grunt or groan, and it gives you more, it makes you more sleepy. And it's generally well tolerated. Most people don't say too much about their surgery, that it wasn't particularly unpleasant or anything like that. We clean up the area. Usually we almost always try to implant this in the left chest. It actually works better because the device is one of the leads of the shock. So since the heart sits over on the left side, the energy is transferred mainly through most of the heart muscle tissue if you ever need a shock. If the device is sitting over here, again, not as much energy is transferred across, so we'd always prefer the left side if possible. It's not always the case, but the device probably works better almost always on the left side. After making you sleepy and we prep the chest, you get antibiotics. We make an incision up here after some numbing medicine, a pocket for the device, put leads down into the heart. It can be one lead or multiple leads. Connect that up to the device, put it all under the skin, sew you up, and then we're done. Some people do testing. I do not do testing anymore. I was trained to do testing, and we did a lot of testing at University of Michigan, including testing the next day prior to discharge for everybody. I really think the medical literature has gotten away from testing unless there's some strong indication to do that. The devices work, they're very reliable, they're very powerful. And the issue is that the bad things that can happen to people as far as dying or just going into very bad rhythms and being difficult to resuscitate happen with the testing almost always, not generally with the surgery itself. So you probably increase the risk of something bad happening if you do testing, and you may not make the device really any safer. The device is not, it does not grant immortality. There are people that die suddenly with a normally functioning defibrillator, especially people who have very, very weak hearts, people that are in heart failure. Those would be the big, the people that maybe are at highest chance of dying despite having a normally functioning defibrillator. And I'm talking about later after surgery. So you want to just make sure that your heart failure is always treated. You're not, not walking around with 10, 15 pounds of extra fluid, 6 months after surgery. That's when the cardiac arrest can happen, and that's when the device will have more problems getting you out of a bad rhythm. The people will almost always spend the night with the initial implant. You get pain medicines and antibiotics overnight. And then you get, we check the device the next day, make sure there's no lead dislodgement. The risk of having the surgery, risk of stroke, heart attack, and death, just with any major procedure or surgery, like if having my gallbladder out or appendix, or if having a colonoscopy. So this is considered maybe a smaller surgery, but there is some risk, and we do operate on the sickest patients in the hospital for the most part. So there is some risk of something bad happening. There's a risk of lead dislodgement. That's why we check the device the next day, make sure the heart hasn't rejected any of the leads, they haven't come out, and then we'd have to do repeat surgery and put them back in. There is some restrictions on lifting your arm for 4 to 6 weeks. You can't lift your arm any higher than this for that time. If you do lift your arm up, you can pull the leads out of the heart. There is a risk of a collapsed lung. We work with needles above the lung. That risk is about 1%. It'll be a collapsed lung. We put in a chest tube to bring the lung back up if that happens. There is a risk of perforation of the heart because we're putting leads down into the heart muscle. If a lead perforates through, it requires a chest tube to drain the blood away from the heart, and then that can generally come out in a few days. Worst case scenario, it requires open heart surgery to fix a hole in the heart if the chest tube doesn't seal up the hole. There's a risk of infection, 1% risk of surgical infection. It may be higher than that. If that happens, the device has to come out and be replaced when the infection's over. There's other things certainly that can happen, but those are the big picture risk and what it's like to maybe have surgery and what to expect.